All right, thank you so much for staying with the Monday Report. The discussion starts right now on this day of the World AIDS Day. And I have my panel of experts here with me, starting from my farthest right, that is Dr. Samuel Kinyanjui. He's a country program director, AHF Kenya. Thank you very much for making time. Next to him is Dr. Lois Ombajo, infectious diseases specialist and co-director, Center for Epidemiological Modeling and Analysis at the University of Nairobi. Thank you for making time. Next to her is Dr. Stephen Dolo, Director, Health Promotion and Program Management at the National Syndemic Diseases Control Council, that is under the Ministry of Health. Thank you for making time. And Cleopatra Wanjiku, HIV advocate and founder, the Voice of a Black Child. Thank you very much for making time. And Dolo, I'll start with you. What are the numbers telling us?
Thank you, Trevor. Good evening, Kenyans. The numbers of the HIV infection are showing a general trend of declining. If you look at where we were 5 years ago in 2019 and where we are today in terms of new infections, they have declined from 41,000 to the current 19,000. That's the overall trend. If we look at the people who are on care, currently we have 1.3 million on care. And in terms of success in treatment, there's something we monitor called 95 target. If we look at the first 95, we have 97% of the people living with HIV who are already on treatment. Then 87% are virally suppressed and 78% are virally suppressed, and 87% are already linked to care. So I would say generally as a country, we are on course to achieving the UN targets of 95.
So why is Nairobi a concern then? Because you were reporting yesterday that there seems to be an increase in infections in Nairobi. Is that what you found out?
This is in terms of absolute numbers. If you look at the numbers that are being given, Nairobi County with new infections of 3,045 looks to be the highest. But again, what is the denominator? It's against 4.3 million if we project from the Nairobi population of the 2019 census. And Nairobi is one of the counties where there is a lot of influx of people during the day, and therefore during the day it could even be going up to 7 million. And these people will seek services, majority in Nairobi. So this data we are seeing for Nairobi is actually against a denominator that could be 6 million, that could be even 7 million. And if we look at the prevalence of Nairobi, it is 3.7%, and the national prevalence is 3%. So it is not so high, it's just close to the national target. But it is the absolute numbers which seems to be high in view of the denominator, which is the high population of Nairobi City County.
In simple terms for the layman, there's an increase in infections in Nairobi, right?
In simple terms, there is a decline because the prevalence in Nairobi last year was 4.2, and now we are talking of 3.7. So Nairobi City County has actually had a response that has led to decrease in the prevalence. And the prevalence is what we use to measure in our population because it's a percentage of the total population. But if you look at absolute numbers, it may deceive you because the denominator is big. Yes.
Interesting. Dr. Kinyanjui, how would you describe the current state of HIV response in Kenya?
I find it interesting. I find it interesting that I find it interesting the way my colleague has interpreted the numbers. But I appreciate that he's taking a trend for the last 5 years. But I would go that long if we were looking at a steady trend. But the trend over the last 5 years has had ups and downs. And we are concerned as an NGO and the other people in civil society because of the numbers we've seen over the last 2 years, 2023 and 2024. We've seen the curve is not smooth, going down. We've actually, the last 2 years, we've actually had data going up. If you look specifically on the numbers, the numbers of absolute numbers, I think 2023 it was either 16 or 17,000. And this year, last year's data you can appreciate is very close to 20,000. So there's almost like a 3,000 in absolute numbers of new infections. The other thing that makes us get concerned is also the mortality, which has almost like stagnated around 21,000 during these years. We are also concerned that the EMTCT, that is the transmission of the virus from mother to child, has also actually over the last 2 years, I think, has also increased from 7.6 to around 9.3 now. So, and when we looked at specifically, I know we are concerned about Nairobi, but we have major reason to be concerned about the ASAL counties, where the mother-to-child transmission rates is double-digit. Some of them over 20%. I think we can look specifically on the counties, but that's a major, major, major concern.
Okay.
So we are concerned about that. And the other thing that we are concerned is about the insecurity that, I know Cleopatra is here, that clients are expressing about them not being very sure whether they will get their medication next time. There are also concerns due to the integration of services that is not guided by a national policy. And as a result, each county is doing whatever they consider best. Some of them including closing of clinics and sending persons living with HIV to the general patient, where they are lost because most of the staff working there over the year have not had the requisite training or experience, and they find themselves inadequate to take care of them. The clients can feel this.
Okay.
So, and the other thing, we did not communicate properly this integration. So most people don't even know what is integration. So they actually, any facility, they hear that facility, there is integration, there's mass movement of clients out. I can say this confidently because for the HIV clinics that we support in Nairobi County, which is mainly Mathare and Parklands and St. Mary's, we've seen more than 1,000 clients come from other clinics and self-transfer them into our AHF-supported clinics. Okay. So strongly appreciate the fact that they feel uncomfortable with an integration they do not understand. They actually feel exposed and like they're being forced to disclose.
What is integration?
Now, that's a big question to ask because if you ask me, I'll give you my interpretation because we do not have a policy guideline to guide what do they mean by integration. By integration, my understanding of it is that we would want all persons who have chronic illness, who live with a chronic illness, diabetes, hypertension, HIV, that is already stable, to go to one clinic. Queue on one queue, be seen by the same doctors, so that when we are queuing like this, if we are your clients, nobody would know why we are here. My colleague here, my senior colleague here would be may be coming because she has pressure. I may be coming because I am HIV positive. Dolo may be coming because he has diabetes, and Cleopatra may be coming because she has asthma. But when you are queuing like this, nobody would know, and this would kill stigma.
Okay.
But when they're being pushed into an outpatient to queue like patient with flu, somebody with jiggers, somebody who came because he has worms and things like that, or pneumonia, it is unfair to them. And that is not the way we manage all other chronic illness. Okay. We've been trained on how to manage the chronic care. Is a relationship. There need to be a very clear arrangement of this, which is not happening now.
Okay. Dr. Mbajo, what have you been seeing over the years? And there's a different trend that's happening now where people prefer to use rapid test kits.
Yes.
Do they work, first of all?
So, thanks, Trevor. So when we think about testing for HIV, for a long time testing was facility-based, either in hospitals or standalone testing centers. But over the years, there have been development of self-testing kits as well, and these are available in country. Self-testing kits come with anonymity. Someone can test without other people knowing. And they're basically good screening tests so that if someone is positive, they can then seek care. They're not meant to take the place of taking care of yourself, that if I test and my partner tests negative, then we're all good to go. But self-test kits are available and can be used, and they work. And really, it's meant to help with screening so that if someone is positive, they can get care early. The concern is where people use the test kits, and because someone is negative, then they're not taking any protection. They will not use condoms and the rest. And I think it's just a reminder that the test kits only test for HIV, but there are other sexually transmitted diseases other than HIV. So where there's a lot of people not taking care of themselves is when we'll start to see an upsurge in infections like syphilis, gonorrhea, and the rest. So it's really to be aware that there's more to sexually transmitted infections than that, just HIV.
Yeah, and Dr. there was an argument we were having with some of my friends. It's a layman argument. But the issue was, if you're exposed to HIV maybe like a week before, so these test kits can't really pick it up, can you still transmit? So, even if the test kit shows negative, can you transmit to your next partner because you exposed a week?
Yeah.
Before.
So the way it works generally is if someone is exposed to HIV now, then the usual tests we use may not pick the positivity because it takes a bit of time for the body to produce what we call antibodies, you know, the HIV virus. So the body produces something to attack the virus, and that's what is picked by most test kits. So if you test too early after exposure, you may have false negatives for a short while. The period shortly after infection is also associated with the time when the level of virus in the body tends to be high. So yes, transmission can occur during that time before some of the commercial test kits become positive. Over time, the test kits are improving, so they're able to pick certain things earlier. But there's usually a short period of time when you may have a false negative, and even then we advise that, you know, someone tests not immediately after an exposure, but even up to a month or more after the exposure. So yes, there may be that risk that where people do not take care of themselves, there could still be risk of transmission. And I think we have to go back to the basic messaging around prevention. It's not just, oh, we are going to use the tests and that's it. Everybody has to take responsibility for themselves and think about how they protect themselves. Do they know their partners? Are they able to use protection? And where there's inadvertent exposure, can they come in so that you're able to advise on what can be done to prevent infection? Okay.
From your analysis, are we seeing any mutations with this virus, or has it been constant over the years?
So the virus is generally constant. So we usually like to refer to the virus as a wild type virus. That's the one that hasn't changed. Most of what we see is where the virus changes in response to interrupted treatment. So for example, if someone is on treatment, the way treatment works is that it has to be taken every single day. That's a treatment that's available in country. As science improves, we may have treatments that are given less frequently. But at the moment, what we have in country is treatment that has to be taken every single day. So if someone doesn't take their medicine every day, people get tired, they forget, and other things. So if someone keeps interrupting the treatment, then the virus mutates. It changes its characteristics so that it becomes resistant to the treatment. And that's a concern because then the options for treating that person are fewer than if they had what we're calling the wild type virus, the one that has not developed any resistance to the drugs that are available.
Interesting. Cleopatra, let me bring you into this discussion. You see now that adolescents and young adults seem to be bearing the highest burden of the new infections.
All right.
What are the key drivers and how can it be addressed? What's going on within your peer group?
All right, thank you so much for having me. And I will start by saying that it's quite unfortunate that the doctors here are doing a lot of work, but we are still having new infections among adolescents and young people. This doesn't mean that nothing has been done. A lot has been done. We are not where we used to be, but from what I've heard and what I deal with young people every other day. But we've normalized. Tumenormalize young people wanaogopa kupata mimba kuliko kupata ukimwi. That is what they say. I will use that. Because people assume that treatment, wanasema dawa ni moja tu. So, unaweza take dawa, haina shida, it's just one. But what we want to tell people is that long life treatment is not easy. I've taken drugs from when I was 13 years. It's not a very easy journey, but people assume and tuko na hiyo tendency, and this generation yetu si kama ya kina daktari, sisi hakuna hawaogopi anything. So that ignorance, and again the information that young people have, they have the information, but they don't have the correct information. I will echo what Dr. has said. we have so many preventive measures. There's PrEP, there's PEP and all that. Young people, mtu ana assume akitake PrEP, may prevent everything else. They don't want to use condoms. We keep telling them that consistent and correct use of condoms will prevent, will give you 99% prevention against HIV, unwanted pregnancies, and of course STIs. But that is not what they want. And again, there's the tendency of this generation we want. And if you find those infections, they are not coming from new generation, from other, kuna wasichana, kuna wababa, kuna vijana, kuna wamama, and all that. And poverty and trying to fit in. Tuko na generation yenye watu wanataka kupata vitu haraka haraka. And so if someone, and you'll find young people, a young girl telling you, I met someone, they want to have sex with me, they don't have they'll give you money, they don't have the ability to consent, or not they'll consent, they don't have to negotiate for condom use and all that. So we have so many factors that are driving this, but I think a lot of information is there, but they don't have the correct information, and the ignorance too, and the assumption. But what we can do, we are supposed to be giving this information. I'm happy we're having this conversation juu tukiwaambia ukweli, because we cannot instill fear. Mimi nikisoma, I didn't even know when I was in primary, I didn't know I was positive, but we used to have those images that really instilled a lot of fear to us, but we cannot use that to this generation right now. What we need is to tell them the truth, to tell them that HIV is there, to tell them that there's medication, but long-life treatment is not easy, to tell them that you need to use, we have preventive measures, we have all those friendly services. We don't want young people, if someone has is exposed to getting pregnant, that means they had a very high chance of getting an STI, of getting HIV. That is the information we are trying to pass. But until we close all those gaps, hakuna mahali tunaenda, na we'll keep getting the rise in the infections among adolescents and young people.
Yeah, Cleopatra, I find that interesting because first of all, young people say wanapima na macho, wanakuangalia wanasema unakafiki sana huwezi kuwa tuko na HIV.
Yes.
But then the issue around the stigma versus the fear. Like when you're growing up, the images of someone who's suffering from HIV were extremely distraught.
Yes.
And that would instill fear.
Yeah.
But now that fear is translated as stigma.
Yeah.
So where do you draw the balance now? Can you still...
We can do that by giving the right information.
But they are not scared of it. You just said that.
And they're ignorant.
Because there's one tablet, I can handle it.
Now, we want to encourage, personally, I'm a very good ambassador of condom use. But again, you know that Katama can not use that term that they usually use in terms of using condoms. They don't want to do that. But we still want to encourage people to go for testing. Most of these infections are coming from people who do not know their status. Because I was trying to ask even Daktari, why is it that I am undetectable? I've taken medication, I cannot infect. We have good drugs that when you take, you become undetectable. Where are we getting these infections? These infections are coming from people who do not know their status. Can we encourage people to test? And watu wa young, not unless mtu apushiwe sana, they will not walk themselves into a facility and get tested. And again, you've mentioned about self-test kit. They're there and they're available, but that is a screening kit. Wengine wanasema sasa venye tu daktari amesema you'll screen and that is it. Unasema uko sawa. Until next time, that's when we'll do that. So let's encourage them to get tested. Let's give them the right information. Kuna wenye wote hawatasikia, but kuna wengine watasikia. But of course, the ministry is doing a lot of work. People like Dr. Kinyaji, they're doing a lot of work. And we have facilities which are youth-friendly, yenye watawork. Because young people wanaogopa, nikienda hapo nipatane na mtu anakaa kama mama yangu, haizi mwambia anything. They will not even say about the exposure. Some get even abused. They will not report. They will not talk about it. And after that, we have prophylaxis that people can get, and we need to close all those gaps. Hizo gaps ziko. Tuambie ukweli, mimi who feel everything as a young person, the information that I've gotten right now, if we pass it to this young generation, we will have saved one or two. We might not get all of them, kwa sababu si wote watakubali, but we'll have. Let's give them the right information. Let's encourage them about testing. Let's create an environment that they feel safe, that I can walk to a facility, know my status, if I test positive, nishikiliwe mkono, start medication. And again, I usually tell them, there is so much life after testing HIV positive. Knowing your status is taking responsibility of your life. It doesn't matter the results. If the results are positive, you have another chance to take medication, become undetectable, continue with your life. If your results are negative, you have another chance to continue putting the preventive measures to maintain the same status.
Okay.
That is what we need to tell them.
Yeah, let me bring in Dr. Ndolo on this. You are the ones who did this research, and the report shows that about 74% of all these new infections, you're arguing that the numbers in absolute numbers, it's not a rise per se, but that infection, 74% is within the age group of 15 to 34. But there's also something Dr. Kinyanjui mentioned, mother-to-child transmission. You would think that this age group is the most informed. But how come there's still rising infection within that same age group? What did you find out and what did you recommend?
Yeah, okay. Maybe we were not clear on where we were interpreting the data in terms of the percentage.
Yeah. I
think we were interpreting the Nairobi County percentage. But now in terms of new infections, 15 to 34 being 74%, that's actually the reality. And she has addressed most of the issues around the young people. And one of the things is also attributed to the success of the rollout of the HIV program, because with time, those photos which were being shown those days, nowadays with good patient care and the rollout of the programs that have been put along by the ministry, people are able to be on drugs, and actually they will not be as thin or living with any issues as it was before. So we have a young generation who have not seen somebody with AIDS, which is the end stage of the HIV disease. And therefore then now the issues she's raising then comes up. And this is actually what we are seeing, many young people. And this is what informed the national theme for this World AIDS Day, which is one race, one goal, ending AIDS among adolescents and young people. And that is what we are emphasizing on currently, on the testing, and the drugs are available in the health facilities. And just to talk about what Dr. Kinyanjui raised about the integration, it is true that the interpretation of integration of services has not been understood by many healthcare workers in different places, and many counties have interpreted it differently. However, yesterday, as we were doing the National Half Marathon, we also launched the Kenya AIDS Integration Framework 2025 to 2030, and the integration is not a fixed prescription from the national government to everyone in the country, but it is offering options of integration based on the health facility infrastructure and the number of patients that are there. So for some health facilities, you'll find it is possible that the HIV clinic can be integrated together with the hypertension, diabetic, chronic care clinic, as the doctor has explained. That's Dr. Kinyanjui. Yeah. But then you can go to a small facility which has like 20 patients, and so only maybe 2-3 clients come every week. You see now, in this case, you may not have a special clinic for these 3 patients every day. So this one may have now to integrate through outpatient. So in this document, the Kenya AIDS Integration Framework, you are able to pick what works for that particular facility. And actually, that is what the Constitution says about healthcare, is a devolved function, so that the counties can make decisions based on the actual circumstances on the ground. I can say that the integration may at some point have been rushed in certain facilities because of the change in the donor landscape, which happened abruptly, and the services had somehow to continue. So at that point, there was some interruption, and actually the National Endemic Diseases Control Council, together with the counties, we did a rapid resource initiative to identify the problems that came with that interruption. And what we found is that actually that movement of patients, everyone to outpatient, was a key concern to the patients, and also the clinicians who were there were not like well equipped with the knowledge. So now, as we address an integration, we are looking at the entire 6 pillars of healthcare provision. So you want to integrate through the leadership of the counties, of the health facilities. You want to integrate the service delivery. You want to integrate the information management system. You want to integrate the financing. And you want to integrate the issues of the commodities and the space. So it's a whole spectrum, and we need to walk this path slowly. But the most important thing is first to ensure there is no interruption in service delivery and no one fails to get medication, no one misses an HIV test when they need it, because we are talking about integrating services.
Okay. Ladies and gentlemen, I have to take a quick break. When you come back, I'll come to you all for solutions now. We've given the general overview of where we are. What do we do now? So I'll give you each about 5 minutes to just explain what we need to do from this point on to deal with the HIV and AIDS. But that is right after this break. You can send in your views as well at Trevor Mbidi at Citizen TV Kenya. Use the hashtag Citizen Monday Report. See you in just a bit.